Hello everyone, hope you're all doing good. In this video, we are going to discuss about menopause. Menopause, there is a definition by WHO for menopause. WHO defines menopause as permanent cessation of menstruation, that is resulting from loss of ovarian, follicular activities. Usually, menopause is considered after a period of 12 months of amenorrhea. Okay, so this period is very important. Okay, so 12 months of amenorrhea, for which there is no obvious pathologic or physiologic cause. Actually, there is a natural diminution of the ovarian function. Average age of occurring menopause is 51.5 years, and for Indians, menopause occurs much earlier, around 47 years. Premature ovarian failure is considered to happen when menopause occurs in less than 40 years of age group. Delayed menopause is named when menopause occurs more than or equal to 55 years. There is a transition phase also. So, menopausal transition phase, that is a span of around 4 to 7 years before cessation of the permanent cycle, before permanent cessation of the cycles, during which the endocrinal and biological changes occur, also with the appearance of symptoms. So, let us now discuss about the physiology of menopause. How does menopause actually occur? We'll see the endocrinological changes first. We'll see what is going to happen normally. There is release of GnRH hormone from the hypothalamus. GnRH hormone is released from, from the arcuate nucleus of hypothalamus, and this is going to act upon the pituitary gland. Which pituitary gland? Yes, it is the anterior pituitary gland. And what is going to be produced? Gonadotropins. What are the gonadotropins? Yes, it is the luteinizing hormone and the follicle stimulating hormone. And this will be acting again on the ovary to produce hormones, namely estrogens, progesterone, as well as inhibin. Clear? So, this is the normal cycle that is going to happen. Now, if we see the hormones produced by ovary, estrogen and progesterone, these are nothing but steroid hormones. They give any kind of stimulation to the pituitary as well as the hypothalamus. Either it can be a positive feedback or it can be a negative feedback as well, right? So, positive or negative feedback to both pituitary gland as well as hypothalamus is given by these hormones, and they will regulate the amplitude as well as the frequency of these hormones. Clear? Right. Now, what about inhibin? Inhibin is produced by the ovarian granulosa cells. They will mostly inhibit. So, they will give only negative feedback to pituitary and it will inhibit the follicle stimulating hormone secretion also. Clear? Right. Now, let us see what are the changes that is going to happen in menopause. So, changes in menopause usually in the late reproductive age, say around 40s, late reproductive age around late 40s, what is going to happen is inhibin secretion is going to reduced. That will cause there is no inhibition. So, what is going to happen? Follicle stimulating hormone is going to increase slightly and due to this, yes, follicle stimulating hormone will recruit more follicles and from the follicles which hormone is going to be produced? Estrogen is produced, right? So, estrogen hormone is also increased. Clear? Right. But what happens means when it is the late menopausal transition period, estrogen hormone is going to get reduced. Okay. But however, remember the other hormones, steroid hormones like testosterone is going to remain unchanged and this time the follicular depletion will start occurring rapidly. Can you understand? Yes. Now, what happens after menopause? So, these are the changes when the menopausal transition is happening. Now, what happens when menopause has been attained? Post-menopause, what will be the changes? Post-menopause, estrogen as well as progesterone levels are going to reduce. Because of the reduction in these hormones, the gonadotropins increase. They will increase more up to 4-fold even. Okay. Then androgens are going to get converted into estrogens, but this time the estrogen form is going to be a less potent form. Okay. So, can you tell me which is the least potent estrogen that is seen in menopause? Yes, it is estrone. Okay. So, estrone. Okay. I tell this one specifically because imagine that after menopause the woman is going to be a single woman. Okay. So, if you imagine like that, then you can remember this estrone is the specific estrogen form in the menopausal period easily, right? Okay. Then also the other androgens, namely dihydroepiandrostenedione as well as the androstenedione are also reduced. Clear? Right. Now, oocyte depletion, how it is going to occur? See, we know oocyte depletion is not a new process that is going to start towards menopause or in the menopause, right? Oocyte depletion is going to happen right before birth itself, right? It starts in utero itself. So, we know around 20 weeks of intrauterine life, there is going to be 7 million oocytes and this becomes around 2 million oocytes at birth and at puberty you will have only around some 20,000 oocytes and among this in the reproductive life only 400 number is going to exhaust, or 400 only is going to get ovulated, and then comes a state of menopausal transition where there is rapid depletion of the follicles, and then comes menopause. What do you think would have happened in menopause? Yes, very good. There will be complete depletion of the follicles. Clear? Right. So, what happens in the endometrium then? In the endometrium, because of anovulation, there is going to be estrogen action which is going to be unopposed by the progesterone. So, we know the menstrual cycle is like this. Yes, this is the menstrual cycle. We have ovulation here, and this is going to be the proliferative phase. This is going to be the secretory phase. So, what is going to happen in the proliferative phase? Which hormone is going to act? It is the estrogen hormone. Whereas in secretory phase, which hormone is going to act? It is the progesterone hormone. I said ovulation is not going to occur. So, which hormone is going to act mainly? It is the estrogen hormone, and there is no opposition from the progesterone hormone. Okay. So, estrogen acts unopposed by progesterone. That will lead to a state of endometrium being only proliferative. So, there is only proliferative or disordered endometrium as well. So, when there is disordered endometrium, what is expected next? Yes, you can expect endometrial hyperplasia, and that will result in endometrial cancer. Clear? Yes. So, let us see the hormone levels in a menopausal woman now. Hormone levels in a menopausal woman. First, let us see follicle stimulating hormone, which is going to get increased, that is more than 40 milliunits per milliliter. Your luteinizing hormone is going to be between 50 to 100 milli-international units per milliliter, and then estradiol is going to be between some 5 to 25 picogram per milliliter. And if you take the growth hormone, inhibin B specifically, and then anti-Mullerian hormone, all these are going to reduce. Clear? So, these are the hormone levels in a menopausal woman. Now, let us see about the effects of menopause. Effects of menopause can be studied into 3 phases. One is immediate effect of menopause, intermediate effect of menopause, and then late effect of menopause. First, we will see the immediate effect of menopause. We can have vasomotor symptoms like hot flushes, sweating, sleep disturbances, and palpitations. Okay. Then we can even have psychological symptoms including mood disturbances. There is sexual dysfunction because there is reduced levels of androgens, which is going to cause decreased libido. Urinary symptoms like increase in frequency of urination, dysuria, recurrent urinary tract infections can also be seen. Somatic symptoms can include headache, dizziness, mastalgia, joint aches and body pain as well. So, these are the immediate effects of menopause. Then we will see the intermediate effects of menopause. Intermediate effects of menopause include urogenital atrophy and urinary incontinence. There can be skin changes, pelvic organ prolapse, so these are the intermediate effects. Now we will see the long term or the late effects of menopause. So long term effects of menopause can include bone changes or cardiovascular changes. There can be dementia and cognitive decline as well. Clear? Right. Now, let me define some of these symptoms. I have told you something called vasomotor symptom in the immediate effect. So, what does this vasomotor symptoms means? See, there is a central regulatory thermodysfunction. Okay. So, there is a central thermoregulatory dysfunction. So, this is mostly seen in the late menopausal transition phase and early menopausal period, and this is prevalent in 75% cases. What are the other risk factors that can lead to vasomotor symptoms means fatigue, smoking and high BMI as well. Clear? But it can be severe in 10% of the people. What is going to happen is there is a sudden feeling of heat. There is a sudden feeling of heat that is felt in the face and trunk, and it will be spreading to the rest of the body. And this is accompanied by anxiety, shivering, sweating as well as palpitation. Okay? And if you see this can occur in a day for 1 to 2 times, and each cycle can last for around 2 to 3 minutes. Clear? This may also be accompanied with other symptoms like there can be sleep disturbances, the patient will become more irritable, lethargic as well as depressive. Clear? Now, let us talk about the psychological and mood disturbances. Psychological and mood disturbances seen in women after menopause may include mood swings, anxiety, irritability. There can be poor memory, loss of concentration as well as depression. Okay. Then how does the skin change? What are the changes in the skin? In the skin, there is loss of collagen. There is going to be thinning and wrinkling because of this, and sometimes there can even be hyperpigmentation as well. Clear? Right. What are the urinary problems caused? Mostly urinary problems are caused due to estrogen deficiency. So, this is going to cause thinning of mucosa as well, which may even cause urinary leak. However, there can be increase in frequency of urine, dysuria, recurrent UTIs as well. Okay, recurrent urinary tract infection as well. Clear? Yes. Then what about the vagina? Vagina is going to become thinner. The rugosity is going to get increased. Abrasions can occur easily. Then petechial hemorrhages can also be seen. Clear? Right. Pelvic organ prolapse occurs when the pelvic ligaments and fascia become loosened, and that occurs mainly due to estrogen deficiency. Yes? Sexual dysfunction, already I told you. There is decreased levels of androgens as well, that is going to cause reduced libido, and that will result in vaginal dryness and dyspareunia. Right? We'll check for the one of the most important complication that can be expected in menopause, osteoporosis. So, what is osteoporosis? Osteoporosis is a skeletal disorder. So, again this is going to start with the deficiency of estrogen. So, when there is estrogen deficiency, there is going to be a low bone mass, which will result in increased risk of fractures. Okay. Fractures can occur at hip or vertebrae or the distal radius. Among this, the most common site is going to be the vertebrae. That's why back pain is the most common symptom. So that's why the most common symptom is back pain in menopausal women, right? Okay. So what are the other risk factors associated with menopause that can lead to osteoporosis? Number one, we can classify them as modifiable and non-modifiable risk factors first. Modifiable risk factors include sedentary lifestyle, or when there is less intake of calcium and vitamin D. Whereas the non-modifiable risk factors include age, race, when they are Asians, when there is a family history, or there was an early menopause, chronic kidney disease, steroid usage, hyperthyroidism, and then hyperthyroidism hyperparathyroidism. Okay, so all these conditions are going to increase the risk of osteoporosis. Now, how to investigate osteoporosis? We'll be checking the bone mineral density, right? So, this diagnose osteoporosis. It determines the fracture risk. Now, DEXA is the primary technique for BMD measurement. Okay, that is bone mass density measurement. DEXA is nothing but dual energy X-ray absorptiometry. Okay, and this is most commonly done at the level of vertebrae, and indications of doing DEXA include females who are more than or equal to 65 years, and if there is other associated risk factors like rheumatoid arthritis or heparin usage, then this can be done even after 60 years of age. Okay. Yes. Sometimes even you can consider the proximal femur also. Clear? There are two scores for detection of osteoporosis after doing your BMD measurement. The two scores are named as T score and Z score. T score is nothing but when the BMD of old aged female is compared with the young female. Okay. Usually this is always negative. Okay. So the ranges can fall anywhere like this. Okay. Start from 0, -1 and then -2.5. So when the range falls between 0 to -1, then it is going to be normal, and when it falls between -1 to -2.5, then there is a state of osteopenia, and when it falls less than 2.5, then there is going to be osteoporosis. Clear? Right. Now, if you see the Z score, here we are going to compare the BMD with that of a age matched population of the women. Okay. So, when this is reduced means then it indicates some other reason for the reduction in BMD. For example, drugs can also cause reduction. Okay. Right. We will see the cardiovascular changes. Usually, women at young age are going to have a less risk for cardiovascular disease than men because of the action of estrogen. Okay. So, estrogen is basically a cardioprotective hormone which is going to cause reduced levels of LDH, increased levels of HDL, and reduction in risk of atheroma as well. Okay. So, because of this change, at the age of 70, the risk for cardiovascular diseases for men and women are said to be equal. Okay. So, equal to men. Okay. And remember, cardiovascular disease is one of the leading cause of death in postmenopausal females. Okay. So, this is a leading cause of death in postmenopausal females as well. So, let us see the risk factors for cardiovascular diseases. Again, I am putting them as modifiable and non-modifiable risk factors. Modifiable risk factors may include risk factors like sedentary lifestyle, obesity, smoking, diabetes, hypertension or dyslipidemia. Okay. Let us see the non-modifiable risk factors. We have family history and age. Okay? Yes. Now, let us start seeing about the management part. So, for the vasomotor symptoms, we have to advise them lifestyle management. Okay? Small changes in their lifestyle, like you can ask them to keep their room temperature low. Okay? So, keep the room temperature low. Ask them to wear light garments, lose weight by exercise, and if they are smoking cessation has to be advised. So, how about the estrogen therapy? Estrogen therapy can be given through the transdermal route because this route will decrease the risk of thromboembolism. Usually, we give micronized 17 beta estradiol, and usually you have to start it with the lowest dose of estrogen. Okay, it will be 1 milligram of oral micronized 17 beta estradiol or else 0.05 milligram of transdermal patch. Clear? Right. So, there can be an exception when a young woman requires HRT, if there was a need for surgical oophorectomy means, then this can be increased up to 2 milligram oral dose and 0.1 milligram transdermal patch. Clear? Yes. Now, how about progesterone? Progesterone is usually added in the hormone replacement therapy to decrease the incidence of uterine cancer or decrease the incidence of endometrial cancer. You can give natural micronized progesterone at a dose of 200 milligram per day for 12 days that can be added in the luteal phase of the cycle. Okay? Or otherwise, you can even give it as a 100 milligram per day dose on a continuous basis. Can you understand? Yes. So, this is cyclical administration of progesterone where you will be adding the dose one day in the luteal phase of the cycle, and this is continuous administration of progesterone, right? Yes. See, previously they were using medroxyprogesterone acetate, but it was associated with an increased risk of breast cancer. Okay. So, we are not using this anymore. Clear? Right. There is a steer group drug called tibolone. Steer means it is a selective tissue estrogen activity regulator. Okay. and this is usually given in the dose of 1.25 milligram to 2.5 milligram daily. There is reduction in hot flush, vaginal dryness, as well as increase in libido as well. Clear? Yes. Now let's see about osteoporosis management. Osteoporosis can be managed by giving a supplement of calcium at a dose of 1000 to 1500 milligram, and you can even give them vitamin D at a dose of 400 international unit. Also you can give hormonal therapy with estrogen. Okay. First line of treatment is usually going to be bisphosphonates, namely the drugs like alendronate and risindronate. This can be given for both prevention as well as management of osteoporosis, and with these drugs the major side effects are going to be gastrointestinal. Other drugs that can be used for osteoporosis management include drugs like selective estrogen receptor modulators, denosumab, teriparatide, and then strontium granulate. Clear? Now let us see about hormone replacement therapy itself. So the indications of giving hormone replacement therapy include when the woman is postmenopausal, but suppose the woman is younger but the ovaries are removed earlier due to any cause, or there was Turner syndrome in the woman, because we know in Turner syndrome there is going to be streak ovaries, the hormone production is going to be low, right? Definitely remember the fact that it is not going to be given to all postmenopausal females. Okay, so these are the criteria for giving, and we have some additional criteria to be considered, that it should be the patient should be repeating. So remember that hormone replacement therapy is not given to all postmenopausal women. Okay, there is a criteria for that also. The woman should be less than 60 years of age group, and she should have passed only less than 10 years, okay, after her menopause. Okay. So what are the indications? Indications of giving menopause include moderate to severe hot flushes or genitourinary symptoms as well. Let's see about the contraindications of hormone replacement therapy. Hormone replacement therapy is generally not given when there is a history of breast cancer, or there is a history of CHT or TAA, history of venous thromboembolism is there, when there is active liver disease, unexplained vaginal bleeding, or the woman has a high risk for endometrial cancer. Clear? Right. There are three options of giving hormone replacement therapy. First option is giving estrogen and progesterone together. This is usually given in women who has intact uterus. Here we will be giving estrogen regularly, and progesterone is added only on a supplementary basis. So, estrogen if you are giving for 25 days, then you can add progesterone in the last 12 to 14 days, that is it. Okay. And the second option is giving only progesterone. Usually this is not given, but can be considered in women who has hot flushes. You can give progesterone up to 3 to 5 years. And the third option is giving estrogen only. This can be given in women who had hysterectomy already. Clear? Let us discuss about the benefits of hormone replacement therapy. Number 1, there is an improvement of vasomotor symptoms, improvement of urogenital atrophy, there is an increase in bone mineral density, there is reduced risk of vertebral or hip fractures, there is reduction in the colorectal cancer. Also, possibly they can even give cardio protection as well. Clear? Yes. Let us see what are the disadvantages of giving hormone replacement therapy as well. So, disadvantages may include by giving estrogen and progesterone together, we are going to stimulate the cell division. So, this is associated with breast cancer. Okay, and this is seen in 90% of the women who are taking hormone replacement therapy. Clear? So, that is the main disadvantage, and it increases the risk of heart disease also by 24%, and that is why hormone replacement therapy should not be given for more than 5 years. Okay, it should not be given for more than 5 years, right? So, this is all about menopause and the symptoms, what the menopausal women face, and what about the management of the symptoms, and about the hormone replacement therapy. So, until we meet in the next video, keep going, happy learning, and take care.